In nursing, we're going to see a wide variety of fractures, and we have to know how to tend to them. So today I'm going to be discussing casts and fractures. So there's a wide range of types of fractures. Today I'm going to focus on compound fractures, comminuted fractures, and green stick fractures. A compound fracture is important because it can potentiate infections due to fact that the bone, as it breaks, it rips through the skin. And as the skin becomes compromised, now we have the risks of infection, pathogens entering the skin and causing the most serious type of osteomyelitis. So that is a focal point that we're going to be always considering when we talk about a compound fracture. The bone rips through the skin and osteomyelitis has a potential for infection. A comminuted fracture is a little bit different. Usually it occurs because of a secondary to a crush injury, and if the bone fracture is fragmented, there's at least 3 pieces or more, and that requires pins to stabilize them, and so hopefully they can adhere and heal more adequately. And then lastly, we have the green stick fracture. The green stick fracture usually occurs to children, and keep in mind that not only green stick, but the spiral fractures are also very similar. We treat them as potentials for child abuse, and we report accordingly until we rule it out. A green stick fracture is interesting because the adult man or woman, the bone has ossified completely. The bone is solid, and it's important that we understand that if it breaks all the way through. But a child, you have to put a lot of pressure, a lot of force in order for it to break. And when it does break, because the bone has not completely ossified yet, it doesn't break all the way through. So for that reason, we always treat it as potential child abuse. Then we got to talk about the potential, the types of casting that we're going to be utilizing. So a fiberglass and a plaster of Paris cast. The first thing you guys got to know is that fiberglass is synthetic. It takes about 5 to 20 minutes for it to dry thoroughly, and it's water resistant. On the other hand, your plaster or plaster of Paris, it takes 10 to 72 hours for it to dry up. And it's not water resistant, and it's significantly heavier than the fiberglass cast. When we have a patient that has a cast on, though, we have to assess the neurovascular status. We have to find out if the edema or the swelling is compromising the perfusion. So for that reason, we assess the neurovascular status. And we can look at the circulation, we can look at the motion, and we can look at the sensation. Now, how do we assess circulation? You can assess the pulse, let's say the dorsalis pedis pulse of the lower extremity. Always remember to compare your affected leg with your unaffected leg so we can have that comparison. We can also assess the capillary refill. We can assess the temperature of the extremity. All of those things will give us an idea if the circulation is intact. The motion, we can ask the patient to move wiggle your toes, move your hands, move your fingers, whatever the extremity is being utilized. And then lastly, for sensation, we want to make sure that the nerves are intact. So we ask the patient, can you feel this or can you feel that as we stroke the side of the foot or the side of the hand? You probably recall the 5 Ps: pain, pallor, we have paresthesia, we have pulselessness, and the potential for, I believe it's paralysis. So those 5 Ps are included in the neurovascular status. Remember, paralysis, pain, pallor, paresthesia, and pulselessness. If you have any of those elements that are affected, it may indicate a potential complication. And the worst complication that we're going to be discussing is going to be your compartment syndrome. Compartment syndrome occurs when the edema gets so profound that it puts a lot of pressure on the blood vessels. So if you take this little circle right here, which would represent a cross section of the leg, you have the skin out here on the outskirts, and then you have the muscles all throughout. Well, in between the muscles, what do we have? We have blood vessels, we have capillaries, we have arteries, we have veins. And so you have arteries here, and you have veins over here. And if you have compartment syndrome that's developing, the pressure that's being placed on those blood vessels compromises the perfusion, and the blood flow becomes interrupted. And that's what compartment syndrome is. Too much of that swelling would put more pressure on the tissues, on those blood vessels, and now you may develop something called a Volkmann's contracture. A Volkmann's contracture is a type of contracture that develops when the muscles develop ischemia because of the lack of perfusion, and now you have a permanent contracture. Keep in mind that in compartment syndrome, we have to assess for it. Now, patients that have fractures will have pain. This is very expected, right? But generally speaking, our initial intervention is to reposition that leg or to elevate it above the level of the heart to promote venous return. If that does not subside the pain, then we go ahead and become a little bit more aggressive in our intervention. So what would be the next step? Would be to medicate the patient. If the pain does not subside after repositioning or elevating the leg, we provide pain medication. If the analgesia does not do the trick, now we have to start considering the potentials for compartment syndrome, and we must report accordingly. The patient will undergo something called a fasciotomy. And the fasciotomy is when you have an extremity. Let's say it's this is the extremity right here. And what they'll do is they'll cut into the skin in this fashion, and they'll ensure that the skin now releases some of that tension, releases some of that pressure, which will enhance venous return and perfusion to the extremity, and you'll prevent the contracture, that Volkmann's contracture. Keep in mind that we use these little devices that look like pizza cutters that vibrate and they don't cut the skin. We can actually go ahead and implement the removal of the cast to ensure that compartment syndrome does not destroy or inhibit the perfusion to the extremity. You also want to keep in mind the potential for procedures. Now, the procedures, of course, we've discussed casting. Remember, we elevate the extremity, especially for the first 24 to 48 hours. We want to promote venous return. We want to ensure that the swelling subsides. Keep in mind, one thing that I forgot to mention is that when the cast is drying, we allow it to dry on its own. But like I mentioned earlier, we will be providing a hair dryer, but in the cool setting, if the patient is suspected of having pruritus, we're not going to be using the blow dryer to enhance or speed up the drying procedure. When it comes to casting, you have to ensure that you elevate to promote venous return, like I mentioned previously as well. Now, traction is an important term because when we have a fracture, the bones are no longer aligned in their anatomical position, right? So we must perform something called reduction. Now, the word reduction means that we're putting the bones back to their anatomical location. And how do we keep them there? There has to be a force that's being exerted to keep the bones aligned in that fashion. And that's where the word traction comes in. There's two different types of traction. You have skin traction, in where you either have a cast and then the pulleys and ropes are attached to the cast itself or to the actual skin, and that's how it's pulling and reducing the fracture and stabilizing it with traction. With traction. And then you have skeletal traction. In some fractures, they require pins and rods that stay inside and come out through the skin. And sometimes some of those ropes are attached to those pins and they provide more stability when you require more pressure or more weight in the traction. Keep in mind that all your traction devices, whether they're skin or skeletal, they're going to have pulleys, ropes, they're going to have these weights. Those weights must hang freely. They should not be hitting the backboard of the bed. And if you ever find them on the floor, you should not attempt to pick them up. You must call the orthopedic surgeon so he or she can intervene accordingly. And then lastly, surgery itself. When we have a fracture, sometimes it requires more invasive or more aggressive intervention. And the most common one that we're going to be discussing is the open reduction internal fixation. Open reduction internal fixation means that they have to cut the patient open. They have to reduce it manually with the surgical procedure. And internal fixation means that there's going to be some pins and rods that stay inside of the extremity on the bone, and then we close it up, we sew it up again. And that's what's going to maintain the reduction and the fixation so the healing process could be more efficient. Keep in mind that you have to know what a trapeze bar is. A trapeze bar allows the patient to utilize his or her upper body strength to grab onto the trapeze and to move and help us pull the patient up as well. When we're repositioning the patient in bed, we will be also, along with the patient, the weights will come with the patient, and we must maintain that traction. We shall never remove the traction because otherwise the fracture will go back into its non-anatomical location and probably rip through muscles and nerves, which will cause spasms and which will cause more pain for the patient and delayed healing as well.